Deep plane facelift, it's a buzzy topic, especially if you read the tabloid craziness about Kris Jenner's facelift. Those 3 words are everywhere. Here's the problem. Not everyone using that term is actually doing it. And the difference between a real deep plane and a technique that just borrows the name, it lives on in your face for years. I'm Dr. Kate D, founder and medical director of Glow Medi Spa, and this is MedSpa Confidential, where we expose the risks, the red flags, and the outright illegal practices happening inside med spas right now, because you deserve to know the truth before you book. Today, I'm with Beverly Hills facial plastic surgeon, Dr. William Harris. By the end of this conversation, you'll know the one question that separates a real deep plane surgeon from someone just charging for one. You'll understand what actually causes that windswept pulled look and how to read a surgeon's results before you ever sit in their chair. Dr. Harris also walks us through what happens when medical tourism goes wrong, because someone has to fix it, and it's not usually the person who caused it. Dr. Harris, thanks so much for being on a podcast today.
Thanks for having me, Dr. D.
So walk us through technically what separates your extended deep plane facelift from a standard deep plane, and then from the techniques that get marketed as deep plane, but really anatomically aren't. What's actually happening there?
It's somewhat complex, but the deep plane surgery in general involves releasing some of the deeper tether points on the face in order to move tissue in a very natural way, but also get a really impactful lift where older techniques didn't get as good of a mid-face lift in other areas. This allows you to really get a nice lift on the tissue. Extended deep plane just has to do with how much we're elevating that tissue. And so if we're able to elevate that tissue farther and release more tether points, then we can move that tissue in a very natural way without any windswept look.
You know, people do their own homework and they're trying to, if they're looking for a true deep plane facelift like you do, what specific questions should they ask to find out what that surgeon's actually doing?
That's tough in some ways because a lot of people market themselves as deep plane surgeons now. And so they're going to answer certain ways. But I think one question you can ask is, are you releasing the ligaments of the face or the deeper tether points? Because there's some disagreement on whether they're actually ligaments, and see what their answer is and see how far that maybe they show you on their own face or your face, how much the elevation is going to be. Because theoretically, if you lift up a centimeter of the deep plane facelift technique, you can say you're doing a deep plane when really it's not the same thing.
So a centimeter is not enough. How much what are we talking here? I don't even know how to do that on my face.
It's not so much about the distance. It's about what you're releasing in the process. But when you're just lifting up the edge of the deep plane, you're not releasing those tether points and those ligaments.
Maybe you can explain a little bit, since most people don't really know, but
Sure.
Obviously, I'm 58. I don't know. We could do this. Probably looks better
great
down below. But what exactly are you doing when you say tether points, without getting too graphic? I don't know. People might get queasy here. But.
So basically you have your skin, and then beneath that you have a muscular layer called your SMAS layer, which turns into your platysma muscle in the neck. And so what we're doing is releasing tether points that hold the tissue down to the bone, essentially, in the mid-face, the lower face, the neck. And so when we release all those, that tissue can be placed where we want it, where it came from, in a very natural way without pulling against a fixed point. And so that also gives more longevity for the lift, because you don't want to age back to that point.
So that kind of lifted look where it's like looks tethered,
overdone.
Like why does that happen?
Essentially, it comes down to tension. So tension is going to be kind of the biggest enemy to a great natural result. And so any evidence of tension on the skin or the deeper tissue is going to translate to a pulled, unnatural look overall. And the deep plane does a great job at taking away that tension from the skin primarily. And then the surgeon is up to kind of the one that's going to dictate how much tension is on the deeper layer.
So can you tell when somebody's had a facelift that's deep plane versus not? We did a podcast recently about Nicole Kidman and Jamie Lee Curtis, and a lot of it was trying to sleuth out, what is Nicole Kidman doing so her face is just not moving. Mm-hmm. And I think you can completely accomplish that with injectables alone. But does a facelift affect that as well?
To answer the first question, there's a lot of great SMAS lifts being done and a lot of great SMAS lift surgeons. And SMAS lift is kind of the prior technique to deep plane lifting where we're just kind of pulling on that muscular layer. But one telltale sign is the cheeks don't get elevated as much. So the lower face will be lifted and more tight. The neck will be taken care of, but the cheeks still sit kind of heavy. And so someone like, I'll use Barry Manilow as an example. When you look at him, you see the cheeks, they're kind of settled here where everything else looks tight. And it's a mismatch. So it's not in harmony. And I think that's, something people notice, but they can't put their finger on of why it looks unnatural. And then past that, with a bad result, you're going to get this windswept look with all kind of tension lines along the face.
So tugging.
Mm-hmm.
Yeah.
Right.
Because I feel like we see that with thread lifts as well.
Yes.
That tugging look is
the same concept because you're pulling against a fixed tissue without releasing.
Right.
Concept.
Do you think that threads have any role? I mean, I've sort of been anti-thread just because of the high complication rate, besides not looking so great. But
so I always advise my patients against threads, and it's not that I haven't seen good results, but the amount of bad results I've seen and the risk involved and the longevity and honestly cost of what you're paying is not worth it. And if you have a complication, surgical removal of the thread is kind of your option. And that's not a great, way.
It's a terrible option. I know I should do a whole podcast about
the risk
threads.
is too high.
I've been so anti-thread. Every time someone says, "Oh, should I be doing thread?" I'm like, no, not at all. Mostly because I had interviewed someone who was teaching a course on threads in a meeting I was at. And I asked him, like, because he was kind of an expert, like, what's your complication rate? And it was really high. It was like, and that's the expert doing it.
Some people's risk tolerance is higher. Even as a provider, anything with that high of a risk, I wouldn't do it.
Yeah. Well, as a non-surgeon, why would I risk something that would require a surgeon to fix it? Like,
Correct.
That sounds terrible.
Correct. For a short-term gain.
Yeah. I am curious, though, do you do much non-invasive work in your practice?
I do. And I've really started doing more as my patient population has grown to younger patients. That obviously changes the needs and goals. So a lot of non-invasive devices. So microneedling with radio frequency, ZERF, which is a new device out of South Korea, which is not involving needles, but it's a radio frequency device that's it's nice because it tightens two different layers in the tissue. And then we do a lot of fat injections in office for skin improvement, which is amazing. And I think the forefront of kind of skin rejuvenation.
Is that autologous fat or?
Yes.
Yeah. So
I don't deal with cadaveric fat, although
from the patient's own body. So autologous is when they take fat from your own body somewhere else, maybe somewhere potentially you don't need as much. Right. And then you kind of make it into injectable form, right? And then
so it's important to know where it comes from. I think typically it's the belly or the thighs or the flanks. It's not liposuction, so it's not done with a big device, done by hand with a syringe, and then we can process it down to various different sizes, even to a point called nanofat where there's no volume and it's just stem cells and growth factors that we can put very superficially to rejuvenate the skin. And I love that.
So you mentioned a younger cohort of your patients. You've been kind of at the forefront of the Forever 35 trend. So the idea that younger patients are coming in to maintain structure rather than reverse decades of aging, like at my age. So how has that changed the conversation? There's no reliable way to know if a med spa is following safety standards or cutting corners. Until now, the Med Spa Board certifies clinics that prove they're doing things right, verified products, licensed staff, and actual medical oversight. It's the difference between rolling the dice with your health and knowing exactly who's holding the needle. If you're looking for aesthetic treatments, go to medspaboard.com to find certified med spas near you. And if you already have a med spa you love and they're not certified, please send them our link. If you're a med spa owner doing things right, get certified and show your patients you're not cutting corners. As a bonus, certified spas also save a ton on malpractice insurance. Do the right thing and go to medspaboard.com. Keep listening, keep asking questions, and stay safe out there.
I think one of the biggest things for me having younger patients is I love having them early so I can help them avoid some of the pitfalls that they could potentially get into. And so I'm a very natural aesthetic provider, but also of the notion you should be conservative and in moderation with any of these treatments, whether it's fillers or energy devices. And so if I can get someone early in my practice and kind of give them a plan moving forward of how to avoid some of the issues you see with people, then that makes my life better to be able to do that for them. And then your second question related to what are we doing differently for those younger patients surgically? Yes, I mean, I've operated and done neck lifts on 28-year-olds, and people say, oh, well, they haven't had aging at 28. And that's correct. There hasn't been a lot of aging, but there's a lot of genetic things that happen with the neck that people just don't like, contour, laxity. And so we can address these things minimally invasive and get them 10 years of benefit without pumping a bunch of fillers or energy devices for 10 years and get them a big change. But fundamentally, it's the same surgery. It's just lesser incision sizes, less downtime, and less to be done.
So just generally easier.
In some cases, not always. Yeah.
What makes it harder?
Well, congenitally, if someone has a larger neck, whether they have more fat in the neck, maybe their submandibular glands are large, the muscle fullness is more, you just have to do more work in terms of contouring before you actually do the lift of the neck itself. Rarely. I typically don't do it alone. I'm not a huge fan of liposuction under the jawline and chin without some kind of tightening of the muscles, because I feel like it leads to problems down the road.
So what about for a young person who just genetically has a big submental fat pad, like even someone like that?
Sometimes, but the truth is that it's rarely that the fat is just below the skin. It's typically below the platysma, and a liposuction device won't ever get below the platysma. And so you just have to be careful, because you take away that healthy fat layer. That's what gives the skin the vibrance and also holds it up. So you can get laxity 2-3 years down the road, even if you looked amazing.
Yeah.
Initially.
And I think actually, like back when Kybella was a thing, which hopefully most people watching and listening to this are not using Kybella anymore. But back when that first came out, they claimed that you could get rid of this fat and then the skin would get tighter once you give the fat, like once you give it. And I found that was completely not true. That in fact, you could take a young person and get rid of all their fat, but the skin hung exactly where it was before. You could barely tell that there was no fat there anymore.
Yeah, there's some component of that. Kybella in general, in my experience, has been very unpredictable. So it may melt fat in one area and not another. Sometimes you can get a paradoxical effect where it actually makes inflammation that then makes the fat look bigger. And so you actually have worse fullness than you had before. And that's a very bad outcome. But again, it's a risk that's too high for me to want to take.
I'm not a big Kybella fan. And honestly, out there, since Kybella has gone out of favor, the people doing it now are the people who are kind of unscrupulous. And I see I'm on several Facebook groups of aesthetic providers in the States. And one of them's all doctors, and the doctors aren't doing this, but some people are out there getting, knockoff, deoxycholic acid that is off of Alibaba or ordered from God knows where. And that stuff can be tainted. It could be God knows what in that vial. So anyway, don't get Kybella and don't get
ordering
fake Kybella.
Fillers from Canada and other places around the world and infecting yourself.
It's horrible. We are doing, at the Med Spa board, we're doing everything we can to make that stop and get people to get certified and be legally compliant.
I think that's good.
Yeah, but definitely wherever you go, make sure they're using real product. That's super important. So I'm curious about your use of like growth factors like PRP. I think that you integrate that kind of thing with your facelift procedures. Can you talk a little bit about that and why that works and why you use it?
Yeah, so PRP is basically taking someone's blood. We take a vial or 2 vials of blood, spin it down, and we remove kind of the red blood cell products and condense it down into a growth factor rich plasma. And then sometimes we'll take it even further into platelet rich fibrin, which is a more concentrated version. And then we can inject that into tissues to basically improve healing time and also the appearance of skin. For facelifting, I like to use it underneath the deep plane flap in order to help that healing process where the flap heals back down to the deeper tissues. And that also improves recovery time beneath the flap.
Wow, that's really interesting. And is there any data on that? Because, we've been using PRP and aesthetics for a long time and we don't have a lot of data, mostly anecdotal, but we use it.
It is primarily anecdotal, but I will say, bruising in my patient population is shorter. And typically at a week, their bruising is all gone. It's very minimal. That's not just related to PRP. I'm not saying that. It has a lot to do with tissue handling and the way everything is done. But I do think it helps in my experience and improves your recovery time and overall result.
Are there any other biologics that you use in your practice?
Use exosomes with microneedling, use PRP for scalp hair rejuvenation, under eye volume improvement. Fat transfer is huge in my office. So as I talked about, a lot of different forms of fat you can do. And then rhinoplasty, I use rib, but those are the primary biologics. Cartilage, but the cartilaginous portion of the rib, but yes.
Sure. Okay. I did do plastic surgery rotation in med school, and it was phenomenal and so interesting, but I never did get to sit on any kind of rhinoplasty. That would have been fun.
Yeah, it's one of the ones that usually gets people. We got to make sure they're not going to faint on those. I've seen a couple go down.
Really? I never did faint in med. Did you ever faint in med school?
No, I didn't. But at some point, nothing causes that anymore.
Well, yeah. Although I have to say, I've seen a couple episodes of The Pit, and that stuff is graphic, man. I mean,
I saw one episode.
I'm a doctor, and I worked in an ER, and I'm like, oh God, I don't want to see that. That's so
Actually,
funny.
I know the ER supervisor for the show who kind of gives the medical input on what looks realistic and what would actually happen. I don't know if medical realism was the goal there.
No, it was all about who is having sex in the call room.
Correct.
Back on it. Yeah.
Whole different storyline.
I never saw that show until later, but since I did my residency in Seattle, it really kind of sucked me in because I'm like, oh, there are some things that are kind of accurate in that.
There's definitely some accuracy there.
So anyway, getting back to facelifts, I'm curious to know a little bit. I know that you have done a number of revision facelifts, that you are okay doing that. You're correcting work done by other surgeons. So I'm curious, without naming people, what are the most common problems that you see when you see a botched result? Is it technique failure? Is it patient selection? Is it something else entirely? Like, what are you seeing that needs to be revised?
I think it really ranges entirely from incisional healing to longevity. I feel like 3-4 years out that the result is not there anymore. The neck in particular, is one of those areas that can break down faster. And then someone wants a correction of just the neck. And oftentimes, unfortunately, you can't do just the neck. You have to kind of redo the whole to get the best results. And then I would say, evidence of tension and the windswept look is a pretty common problem, especially people coming 10 to 15 years down the road. And now they know they have the option of a deep plane lift. You can potentially correct it.
So sometimes you're correcting something that happened recently and it doesn't look good.
Right.
And other times it's just either it's not lasting as long as it should, or we're just, 10, 15 years more of aging and you're correcting that.
They're ready to do something again.
Yeah.
Correct.
So of all those, besides this windswept lift, I kind of love that. Are there any other specific problems that you see more routinely that are just, people keep making this mistake and it just doesn't look good? Or
I think it kind of runs the gamut. Incisional healing is really important, and everyone kind of talks about, it's suture technique and it's how you close the skin, but really it's the whole surgery. So the whole surgery dictates how that incision is going to close, how well it's going to heal. Because if you're able to take the tension off the skin effectively, then the suturing is very important. It needs to be meticulous, but it's not as important because that skin's already going to be twisting. It's not going to have tension. So all you need to do is throw the sutures in there to kind of tether it for a little longer. And that's really what it comes down to. The whole technique dictates the incisional healing.
And that makes total sense to me. And just so since I'm not a surgeon, but that plastic surgery rotation was very early in my med school career. And after that, I did a bunch of other, general surgery, other surgical subspecialties. And I was sort of horrified by the way people sewed people up, right? Like, well, that's not going to heal, right?
Right.
And so for everyone kind of listening to this, like maybe you can explain why careful lining up of the tissues without tension makes it heal better, why plastic surgeons are so good at that.
For me, my training has always been entirely on the face. And so no matter what we were doing in residency, whether it was cosmetic in nature, every time we close that skin after any incision, whether it's a thyroid surgery or submandibular gland removal, you're going to have a very visible incision that needs to look as good as possible. And so tissue handling technique training for plastic surgeons, head and neck surgeons is just so extensive compared to a lot of specialties. And you learn what's going to really heal better in the long term. And one example of that, for instance, is a suture of an incision can look perfect initially, perfectly lined up. But if you don't evert the skin edges effectively, ultimately when it heals, you'll get a dip in the skin. So, eversion of skin effectively is going to heal better down the road, even though initially it doesn't look as good. So these are things you have to explain to facelift patients, for instance, of why does that incision look like that? But all these things are kind of knowing what's going to happen down the road in terms of peeling.
And that's so important. So, when I have a patient who wants to go get a thing removed, when it's on your face, it's obvious, like, okay, go to a facial plastic surgeon or a plastic surgeon who can do that and make it look beautiful. But a lot of people don't realize, like, if it's on your back or somewhere that's going to show when you're in a bathing suit or whatever, people still care. And I always tell them, like, if you want that to look nice, go to someone who can sew that up, because otherwise you're going to have a big old scar on your back. You know?
And that, I think, not to disparage any colleagues, there are a lot of great ER surgeons, general surgeons who do a great job closing. But on the whole, the level of training and experience in soft tissue handling is just very different when you get into plastic.
When it's trauma, when you're doing something fast, or for OB-GYN, you're doing an emergency C-section, you're worrying about these things.
You're just trying to save a life. Yeah.
Absolutely. But I can just tell you, like, in plastics, of course, it matters what layer you're sewing, the what, and so things can still move. I've seen people suture up like one giant layer, and I'm like, oh my God.
What's going to happen? You remember that plastic rotation well.
Oh my God. And this was a very long time for me. So
that's very true. There's a lot of glide planes in the face, and that's really important.
Yeah. And but it really made a huge impression. You're reconstructing something that has been destroyed in one way or another, whether it's surgically or by trauma, and you're trying to make this look normal again. And it's the most creative thing I've ever seen. It was like trying to create human, tissue and beauty out of other parts,
And I've done a ton of that. My practice now is primarily, cosmetic, but in residency did a lot of cancer reconstruction. And it really is some of the most creative work there is in terms of giving function and, appearance and facial health back.
It's really beautiful and elegant, really. Surgery.
Very, very noble. So
if somebody is looking to have a facelift or any other plastic surgery done, and they're trying to make a decision, of who to go to, if they're interviewing, 3 different surgeons, what should they ask? What should they look for?
So I think, do your research before you set up your consults in the first place. And I would recommend everyone talk to, 2 to 3 surgeons before they make a decision. Obviously, at a certain point, it's cost restrictive in some cases because there's a fee for consult, but it is your face. So I would say at the end of the day, it's worth paying that consult fee in order to get the right surgeon. And then I think one big thing is make sure there's a personality match and an understanding where you feel like your surgeon actually listened, understood your goals, and that their aesthetic aligns with yours. Then it's kind of getting down to looking at all their before and afters, making sure that's the look that you're going for. If it's a natural look, if it's not a natural look, it wouldn't be with me, but then that's your person. And then making sure, obviously, they're qualified. So either board certified by the American Board of Plastic Surgery or American Board of Facial Plastic and Reconstructive Surgery. You can call yourself a cosmetic surgeon and be of any specialty with very minimal training. So I think that's something to look out for. If it says cosmetic surgeon, you need to be more wary.
So, and I have talked about this, but I think that's really important to repeat that. So if you see a website or name on the door and it says, whoever, MD, or DO cosmetic surgery.
Mm-hmm.
That is not a plastic surgeon, because no plastic surgeon calls himself a cosmetic surgeon.
Correct.
So there are these cosmetic surgery courses and even fellowships, but you can actually do that from family medicine, from any other specialty. So you don't even have to be a surgeon to call yourself a cosmetic surgeon. So it doesn't mean every single person who's done that's a terrible surgeon, but
No, I think I just want to add on to that. A lot of people say, well, I went to a cosmetic surgeon, I got a great outcome. And that's great. But the problem is that if you run into an issue, do they know how to deal with it? Or if you have a complication, or if you have something in the aftercare period, are they going to know how to deal with that? Certain people's anatomy are much more straightforward than others. Some people are tougher. And so I think when it comes to your face and neck in particular, you want to have the most breadth of training on that surgeon before you go.
Yeah. So the two pathways that plastic surgeons have, or surgeons have to become to do a facelift, or they can either do a full residency in plastic surgery, which is generally 5 years of general surgery, and then I think a 2-year plastic surgery fellowship.
3 years, yes.
Or three years. So yeah, sorry, really long time. Or you can do ENT, ear, nose, and throat, or otolaryngology, and that's a 4-year residency, right?
It's integrated now, so typically don't do a separate internship. So 5 years of residency, 1 year of fellowship, and then the other alternative would be to do a 6-year plastics. Yeah. So there's 3 different ways.
And all of that means it's ridiculous amount of time in order to have that subspecialty, right? 6 years of residency and fellowship after med school to do radiology. And that was a decade of my life,
Yeah.
And it's the same or worse. I would say plastic surgeons and neurosurgeons are probably the most highly trained doctors that we have. Right? But I think that really matters who you go to.
It does.
So,
it does.
So this is a question I like to ask everyone who, especially ER docs and surgeons, what are the absolute craziest things you've seen that have walked into your office that you think, oh my God, I can't believe this happened?
I'll go most recent, I guess, because there's a lot. But most recently, I had a gentleman who had fairly significant scalp necrosis, probably 30% of his scalp, from a hair transplant that he underwent in Turkey, that he, had price shopped, and had a friend who actually had done it and had an amazing result. And so that's kind of where I was going earlier. It's like, just because one person has an amazing result doesn't mean that percentage of amazing results is high. You have to be careful listening to a friend. Same clinic. Yeah. And it sounded like it was kind of a conveyor belt type situation, but yeah.
Turkey and I think Korea are the top 2 countries in the world for hair transplants.
Mm-hmm.
And it's just cheaper there. People fly there. And so that's really interesting, because obviously, we're not there, but so he had a necrosis of his scalp, which means that the skin dies, which means your hair also dies.
Right. Tissue underneath the skin, actually, in his case. Yeah. So then you're dealing with, is it down to bone? And then is there infection risk more so than that can go through the bone? And it's a bad complication. He did okay. We put him on antibiotics. We did a lot of debridement, and then he did a lot of hyperbaric oxygen therapy, as well as a topical ointment antibiotic. So we kind of hit it from every possible angle. And then later we did some PRP to kind of help the tissue along as it was healing.
Did any of the transplanted hair survive?
It's yet to be seen, but I think it'll be sparse. You can transplant into scar tissue. It typically does not have as good of a take, obviously, because it's not healthy tissue, but you can do it.
So that not only cost him the flight to Turkey, the cost of the transplant itself, and then the cost
of coming to see
treat
me.
it.
Yeah.
Wow. So
that's one of those things when you do medical tourism. If you have an issue when you come home, then you're going to a surgeon or a physician who doesn't know what was done, and they're trying to start from zero and help you, but it makes it tougher.
I was at a conference when I was first starting in aesthetics, and there's a Harvard laser course that I was taking, but they were doing controversial cases or something, and it was a guy who had flown to London to get a penile enlargement with filler. And they put 12 syringes of Voluma in his penis. And that did not go well because it cut the circulation off to his penis, and he basically had a gangrenous situation going on. It did dissolve because it was at least a hyaluronic acid filler, but he did not want. So the funny thing is, he didn't want it dissolved because he paid so much money for it. He's like, I paid money for that, but then they had to dissolve it all.
There's a lot of people doing that in LA, and there's a lot of complications. So I would recommend against that. One of my colleagues is a specialist in basically rehabbing and improving those situations. And the stories I've heard from him are pretty nightmarish.
So he actually specializes in fixing people after they've had this go wrong?
It's not his primary specialty, but he's become the go-to guy to fix these issues. Yeah.
The go-to guy to fix. Well, so you heard it here first. Okay.
I won't say his name because he might not want to be known for that, but he does a lot of it.
Okay. But, call Dr. Harris's office if you need a referral.
You can get the name from the office.
That's so it. Can it be done safely?
Well, luckily, what you're saying is the easiest route is dissolving. If it's a dissolvable filler, a lot of these fillers, especially they're done in Miami, from the stories he's told me, are not dissolvable. They're permanent fillers. So that involves a long incision to remove all of these. And that's the same with the face. So if you have issues with permanent fillers in the face, surgical removal is the option. And
I've said it a million times. I'll say it again. No non-dissolvable fillers ever. So never. No Bellafill, no Radiesse. Some people use Radiesse as hyperdilute as a biostimulatory. I'm like, okay, fine. But otherwise, super dangerous. One of the criteria we have for the Med Spa board is we will not certify anyone who's using non-dissolvable fillers. I don't understand why anyone who has any medical intelligence would use them, because they're just risky.
Yeah. And, some people have done them tastefully and had great results. But I think, again, I don't use Radiesse. I think the risk profile is too high. And there's other options.
Is there anything else you'd like to leave our listeners and our viewers with? Usually I'll ask, if you had to give people one piece of advice or two pieces of advice when they're thinking about plastic surgery, what would you say?
Yeah, I would say find a provider, obviously with all the qualities we talked about earlier, but find a provider that will say no and stop you from yourself in some cases. Because typically when I see a really botched job, whether it's a lot of fillers, bad surgery, or whatever it may be, it was a combination of maybe the patient wanted something that shouldn't have happened and was unrealistic, but then the provider to do it. And it wasn't the best combination. So it's certainly on the providers too. But if you find a provider that's, going to tell you no and guide you in the right direction with a long-term thought process, then that's the best. And if you go to someone who only has two tools, those two tools will probably always be the answer. And so go to someone who gives the full breadth of options and will refer you out to someone if they don't do it.
Yeah, absolutely. If you're finding yourself doctor shopping because nobody's telling you the answer you want to hear, it's probably because it's not a good answer.
That's correct. There will always be someone that will say yes. I tell people that all the time. So you can go down the street one block, there'll be someone to say yes, but I wouldn't do it.
Thanks for listening. If this episode opened your eyes to something you didn't know before, share it with someone who needs to hear it. Subscribe so you don't miss the next one. And drop a comment telling me your biggest takeaway. I actually read them all. Join me on this mission to keep you safe and push this industry to do better.